Hello everybody and welcome back to another anatomy tutorial. Today we're going to be looking at the anatomy of the elbow joint on an MRI scan. Now some of the anatomy here is going to be assumed knowledge, and if you feel like your elbow anatomy is a little bit sketchy, I'd highly recommend going back to the elbow radiograph talk that I've given before. We're going to cover a lot of what has been talked about in that talk here in multiple planes on an MRI. So we'll start by having a look at the bones, then we'll look at the tendons and the various muscles that are associated with them, before moving on to the ligaments of the elbow joint, and then finally looking at some of the nerves that cross the elbow joint. So let's start by having a look at the bones. We know that there are three bones that make up the elbow joint. Our humerus superiorly, and distally we have our radius on the lateral side and our ulnar on our medial side here. The distal humerus can be separated into multiple different sections depending on the ossification centers that created that distal humerus. We've got our lateral epicondyle laterally on the side of the radius, our medial epicondyle on the medial side of the elbow joint. Then we have our trochlea, which articulates with that trochlear notch of the ulnar bone. And then we have our capitellum, our small head here, that articulates with the radial head at our radiocapitellar joint. So we have our radiocapitellar joint laterally, our ulnar-humeral joint medially, and our proximal radio-ulnar joint here, where that radius can rotate around in this pivot fashion and articulate with this proximal ulnar here. So our radial bone can be separated into different sections. We have our radial head here, the part with the shallow fossa that articulates with that capitellum, our radial neck heading off towards our radial shaft, and we can see medially here this radial tuberosity where our biceps brachii tendon is going to attach. Our ulnar bone can also be separated into multiple parts. If we go right posteriorly in the image here, we can see our olecranon posteriorly, our trochlear notch coming around to our coronoid process anteriorly here, and then the ulnar bone heading down towards the ulnar shaft, as well as having our ulnar tuberosity here where our brachialis tendon is going to insert, and we're going to have a look at that when we look at the tendons. If we look at this in the sagittal plane, we're cutting the humerus here in the sagittal plane. You can see our trochlea here, our trochlear notch of the ulnar with our coronoid process, and posteriorly our olecranon. We can see there's a depression, a shallow depression here called our olecranon fossa that's filled with fat. And we know that if we get a joint effusion and that fat pushes away out of that fossa, we get a radiological sign on our radiographs called the Sale sign posteriorly and anteriorly as well. This fat should be tightly opposed to the bone here like we can see here. This allows that olecranon, when we extend our arm outward, to go into the space without impinging on important structures, as well as providing some cushioning. The same happens when we flex our arm. This coronoid process can go into the coronoid fossa there, which is this fat-filled space. Now there are multiple tendons or muscles that cross the elbow joint to allow for extension and flexion of the elbow joint. Our major flexors of the elbow joint are our anterior upper or brachial section of the upper limb. We all know our biceps brachii, biceps meaning two heads. We've got a long head that we looked at in our shoulder MRI talk, which heads all the way to that supraglenoid tubercle. And then we've got a short head coming to our coracoid process of our scapula. They then head down into the upper arm and fuse to form our biceps brachii tendon. We know that biceps brachii tendon crosses the midline and attaches to the radial tuberosity. So let's find this radial tuberosity here. And we should be able to follow the biceps brachii tendon up as we head anteriorly. You can see those two heads of the biceps brachii muscle coming together, forming the biceps brachii tendon that heads its way down to the radial tuberosity there. Our ulnar tuberosity has our brachialis muscle. Now the origin of our brachialis muscle is on that anterior surface of our humerus, and that tendon heads across the elbow joint and inserts onto the ulnar tuberosity. So let's find our ulnar tuberosity. We know it lies anteriorly to the ulnar here. It's quite difficult to see it on the coronal plane. I'll show you it in the sagittal plane now. As we head up, we should be able to see a tendon forming here, following my mouse across, and that tendon is our brachialis muscle tendon. Let's have a look at that on the sagittal PD. It's much easier to see. Here's our brachialis coming from that anterior portion of our humerus and inserting onto that ulnar tuberosity. We should be able to head out more laterally and see this large biceps brachii tendon that attaches to that radial tuberosity. Here's our radial bone, that medial surface of our radial tuberosity heading across there. We know our extensors of the elbow are our triceps. Triceps, 3 heads. So we've got a lateral head, we've got a medial head, and in between those we've got the long head of the triceps. Now if we find our olecranon, we know that the triceps tendon attaches to that olecranon. You'll see there's a tendinous attachment posteriorly and then a muscular attachment slightly more anteriorly onto that olecranon. So it's really important to assess whether the tear involves both the muscular and the tendinous section or just a partial tear through either the tendinous or muscular sections. This is our lateral and our long head of tricep making this tendinous section. And then our medial head, the one that lies deep to the lateral and the long head of triceps, then gives us this muscular attachment onto the olecranon here. So those are the major flexors and extensors of the elbow, but we have a couple of muscles that cross the elbow that are involved in wrist flexion and extension. And those actually don't contribute to flexion and extension of the elbow. Their action is at the wrist joint. The reason they don't contribute to flexion and extension of the elbow is because they lie on the lateral portions of this elbow. And we know the elbow is a hinge joint, but we don't get lateral movement of our elbow. So any muscles going across that lateral section are not going to allow us to move the elbow in a volar or valgus movement. These muscles then cross the wrist joint and allow for flexion and extension of both the wrists and the fingers. So let's start out laterally. Now, as with any joint in the body, our tendons lie lateral and our ligaments lie medial. Our ligaments keep the bones together. We don't want tendons interfering with the ligaments there. Our tendons are lateral to those ligaments to allow movement across the joint. So let's have a look at our lateral epicondyle. Here we know it's lateral because we can see our radius on this side. And this is the common extensor tendon. So the lateral part of the elbow is involved in extending the wrist. You can actually feel on yourself, if you extend your wrist and you put your fingers on either side of your elbow, you'll feel it's the lateral compartment and posterior compartment of the forearm that flexes when you extend your wrist. The medial compartment is involved in flexion. So here laterally we have our common extensor tendon. You can see it out here laterally. There's a small bit of hyperintense signal here separating this common extensor tendon from our ligaments of the elbow. We can follow that common extensor tendon down into the forearm there. The common extensor tendon is what gives rise to our extensor carpi ulnaris, our extensor digitorum, and our extensor digiti minimi. So 3 muscles are arising from this common extensor tendon origin. As you can see, superiorly and more laterally to this, we also have other muscles that originate from slightly higher up than this lateral epicondyle, and that's what's called the radial portion of our posterior forearm muscles. That's where our brachioradialis originates, which allows for some flexion of the elbow as well. It inserts into the styloid process of the radius here distally. Our brachioradialis originates higher up there, and it's at that point as well where our extensor carpi radialis, longus and brevis also originate. They don't actually come from this common extensor tendon. So that's our lateral portion. The main tendon here is our common extensor tendon. If we go to the medial side, we can see our medial epicondyle of the humerus here. We know it's medial, we're on the side of the ulnar here, and we should be able to see the common flexor origin here of our tendons here. So you can see a tendon coming from the most medial part of this medial epicondyle, and that heads off into our flexors of the forearm. We can see this muscle wrapping around here, our pronator teres, teres meaning round, it's our round pronator. That means we've got another pronator which is more distal in the forearm, which is our pronator quadratus, our square pronator. Pronator teres is the first one that's coming off that common flexor tendon origin here. We also have our flexor carpi ulnaris, our flexor carpi radialis. We've got our flexor digitorum superficialis and our palmaris longus, all coming from that common flexor origin of the medial epicondyle, our common flexor tendon here. So our tendons lie more superficial than our ligaments. Let's have a look at some of the ligaments that provide stability to this elbow joint. We've got lateral ligaments and we've got medial ligaments. I'm going to start on the medial side because it's a little bit more simple and we're at the right position to have a look at this ligament. You can see the coronoid process here of the ulnar bone, and this most medial little bit here is what's known as our sublime tubercle, and that's what gives rise to the anterior band of our ulnar collateral ligament. The ulnar collateral ligament comes from the ulnar and heads off towards the medial epicondyle here. It actually inserts just below that common flexor tendon here. The largest part of the ulnar collateral ligament is this anterior band, and it's the one that we're going to be looking at most when we're assessing for injuries. If you've got people who are throwing a lot and they're giving a lot of valgus pressure on that elbow, it's this tendon that experiences a lot of the force coming through it. Baseball players or cricketers that are throwing like that, they get lateral compressive symptoms on this side, and then we get tears in the anterior band of our ulnar collateral ligament on this side. You'll see that the signal here is very hypointense at that sublime tubercle here. There's a good connection here, and we mustn't see fluid coming in between this ulnar collateral ligament and our sublime tubercle. That would be what's known as the reverse T sign, which suggests a tear at this point. As we head more proximal or superiorly in the image, we can see the signal becomes a little bit more heterogeneous before it inserts here below the medial epicondyle, and that's normal for the anterior band of the ulnar collateral ligament. If we were to head a bit more posteriorly, this ulnar collateral ligament thins out like this, and this is the posterior band of the ulnar collateral ligament. It's almost continuous, it's just a thickening anteriorly, and then it heads out posteriorly and gets thinner and thinner. There's also a transverse ulnar collateral ligament, which kind of forms a triangle with these, our anterior, posterior, and transverse. It's not really a ligament that you look at much on an elbow MRI. It's a very thin band that doesn't actually cross the joint, just comes from this medial portion of the ulnar bone and heads out towards the lateral portion here of the olecranon posteriorly. You might see a little bit of it there. Let's head on to our lateral ligaments here. We can see our common extensor tendon here separated from this band here, which is our radial collateral ligament, our lateral collateral ligament. Our radial collateral ligament heads off from this lateral epicondyle slightly more medially to this common extensor tendon and inserts into the annular ligament that we talked about in the X-ray radiograph talk that wraps around the head of this radius. And we're going to have a look at axial imaging when we finish off this talk, looking at all the various bits of anatomy, and we'll see that annular ligament wrapping around this radial head, allowing for that pivot motion while keeping that radial head in place. So we've got our radial collateral ligament that then inserts into our annular ligament. Now our annular ligament heads off from the sigmoid crest on the ulnar bone here, both a volar and a dorsal sigmoid crest, which I'll show you again on the axial, and it wraps around, so it inserts in both the volar sigmoid crest and the dorsal sigmoid crest. There's one more ligament that provides stability at the elbow joint, and it's a posterior ligament that heads from our ulnar bone posteriorly, wraps around the posterior portion of our radial head, and then heads up and inserts onto that lateral epicondyle. We can see it here. This part of the ulnar bone is what's known as our supinator crest. We're going to look at the supinator muscle that comes off here. And we can see this ligament heading out superiorly and laterally, wrapping around the radial head and then heading up towards this lateral epicondyle here. So we can follow it. Let's follow it down, and we can see it coming down into that ulnar bone there. So let's have a look at an axial PD here and consolidate all of that knowledge, bring it all back together. We can start superiorly in the humerus here and head down. We know that this here is lateral because we can see this anconeus muscle here, and our ulnar nerve, which we're going to look at here, is medial. So our anconeus muscle lateral here. If we scroll down further, we should see our radial head come into view there. Look at this annular ligament heading all the way around the radial head there, this dark structure here, from our volar sigmoid crest heading all the way around to our dorsal sigmoid crest of the ulnar bone. We can see the olecranon here of the ulnar posteriorly, and as we head up, we should see this triceps tendon, both the muscular and the tendinous portion. You can see the heterogeneous signal in this tendinous portion of our triceps tendon, and that's normal for the tricep. Let's go up into the brachial portion of the upper limb and start at our biceps brachii here. We should be able to follow this tendon down, and that will insert into our radial tuberosity. Follow it down. There is our radial tuberosity lying on the medial surface of the radius. Again, if we follow that up, we should be able to look at our brachialis muscle and the brachialis tendon that heads down into our ulnar tuberosity. We can see it inserting there onto the ulnar tuberosity. You can see how the ulnar tuberosity is more anterior. Our radial tuberosity is more medial here. Let's have a look at some of the ligaments and tendons on the lateral portions of the image. So we've got our radial side here, so we know that this is our lateral epicondyle. We should, as we scroll down slowly, see a separation of our common extensor tendons here and our radial ligament here. So our common extensor tendons go off into the extensors of the arm, our extensor carpi ulnaris, our extensor digiti minimi, and our extensor digitorum. Further up, we've got our extensor carpi radialis, longus, and brevis, as well as our brachioradialis, which is this large muscle lying anteriorly here. On the medial side here, we can see our common flexor tendon origin, which gives rise to those 5 muscles, our pronator teres here, our flexor carpi ulnaris, flexor carpi radialis, our palmaris longus, and our flexor digitorum superficialis muscles. Now, it's not necessarily important to remember all of these muscles. Some of them have a distinct appearance, like the anconeus, like the large brachioradialis, and like this muscle that wraps around the radius here as our supinator muscle, coming from that supinator crest that I talked about earlier, where our lateral ulnar collateral ligament, you see it coming there, lateral ulnar collateral ligament wraps around the posterior portion of the radial head here and then heads up towards our lateral epicondyle. You can see how that gives us a posterior lateral stability here. If we disrupt this ligament here, our radius can dislocate posteriorly there. So on this lateral side, we've got our lateral ulnar collateral ligament, we've got our radial collateral ligament, and we've got our annular ligament. On the medial side, we've got our ulnar collateral ligament that separates into 3 separate sections, our anterior bundle, posterior bundle, and that transverse section. Now, if we go to our medial epicondyle here, we can scroll down slowly and we should be able to see here that anterior bundle of our ulnar collateral ligament. And here we can see that thin posterior bundle heading off there. And it's very difficult to see our transverse ligament that heads from that coronoid all the way around to the olecranon. That anterior bundle we know inserts into the sublime tubercle of our coronoid process. What else do we need to look at? The last thing we need to look at is the nerves that cross the elbow joint. The easiest nerve to look at is this medial nerve posteriorly here that comes through our cubital fossa, which is known as our ulnar nerve. This is our ulnar nerve. You can see how superficial it is. This is our funny bone. If we were to apply direct pressure on here, putting pressure on that ulnar nerve and our medial epicondyle here, we'd get that nerve-like pain shooting up through our arms. That's our ulnar nerve heading down. It gets embedded in this flexor carpi ulnaris on this side and heads into the forearm. Let's look for our radial nerve. We know that our radial nerve starts posteriorly and then it wraps around the humerus laterally and then heads into this anterior compartment. The best way to find it is to go to the elbow joint and see this large brachioradialis muscle here. Posterior and slightly medial, we should see these 2 radial nerves. They've split here into a superficial and deep branches. And as we head down further, we should see that this supinator muscle comes around between the brachioradialis and the supinator muscle here. We get that deep branch heading backwards, giving us our posterior interosseous nerve here. On the medial side, let's head back up to the elbow joint, find our medial epicondyle, and see our pronator teres coming around here. There's 2 heads of the pronator teres. In between that is where our medial nerve runs. That medial nerve, as we head further down, is going to embed itself in that pronator teres and also send off 2 branches. One that goes off towards the carpal tunnel, supplying muscles of the hand, and another that heads off as the anterior interosseous branch. So those are the 3 main nerves. Often it's difficult to see the nerve, but you can see the perineural fat. These are our Axial PD's non-fat sat images. So our fat gives us good contrast for our tendons, for our ligaments, as well as our nerves here. So that's a whistle-stop tour through the major structures that cross the elbow joint. Obviously, when you are looking for pathology, you need to go and have a look at marrow signal. You can look at your PD fat sats as well, looking at the marrow, looking at the bones themselves, looking for various fractures. And I just want to touch on 2 things before we end off that people commonly get confused with. The one is we can see our ulnar bone here on the sagittal PD, our olecranon coming posteriorly and this coronoid process coming anteriorly. You see the articular surface here of our trochlear notch. Then there's a disruption here, and then we get a continuation of that cartilage there. this is normal. This is what's known as our trochlear ridge. And if we were to look at the articular surface of the olecranon and that coronoid process in that trochlear notch, there's actually a small gap between that cartilage there, which is normal. That small gap gets bigger as we head out laterally. See how much bigger it gets. And if we head out medially here, it also gets bigger. So on the peripheries, that trochlear ridge becomes bigger. That's not a foreign body. That's not a disruption of the cartilage there. Lastly, if we head out towards our capitellum, so we can see our radial head here that articulates with our capitellum, we can see the articular surface of this rounded part of the capitellum. We get a flattening out here at the posterior portion of the capitellum where there is no cartilage. That's completely normal. When we cut this in coronal, sometimes we will see radial cartilage and no capitellar cartilage. Let's see if we can see it here. We can see, let me go posteriorly. See how we've got cartilage here on our radial head, but we've got no cartilage here on our capitellum. That's normal. That's just the posterior surface. We haven't lost any articular cartilage on that capitellum. So we've gone through the elbow joint, looked at the bones, the ligaments, the tendons, some of the nerves that pass through there. I hope this has helped you at least approach an elbow MRI. Once you know the anatomy well, then you can figure out what is wrong within an image. Has the ulnar nerve dislocated out of this capital groove here? Have we got a fracture of this coronoid process because of a posterior dislocation of the ulnar there? We know what normal anatomy is, which will allow us to look for pathology in the future. So I hope this helped. I'm going to move on to the foot and ankle next week, starting with a radiograph, then heading to an MRI. So be sure to check those out next week, and I'll see you all then. Goodbye.